All right, let's go ahead and jump in. My name is Ariana Boschera. I am the project coordinator for the Disaster Health HIT team and hosting this meeting. We're very excited to hear from Dr. Gillum today. Dr. Gillum attended medical school at the University of Colorado at the Anschutz Medical Campus. He then completed his emergency medicine residency, where he served as chief resident before completing his EMS fellowship, both at Denver Health. After the fellowship, he worked in multiple South Denver area emergency departments, and then as an assistant professor of emergency medicine at the University of Colorado School of Medicine in UC Health University Hospital. He currently works as an emergency physician at Denver Health, and he is also the medical director for Denver Fire Department, Denver Police Department, Denver 911, Denver Sheriff Department, and the Denver Department of Public Safety. He's also one of our HIT team members, and he's been a valued member for a good amount of time, and he is going to go ahead and present on anthrax and some bioterrorism considerations. So we're very excited to hear from you, and I will pass it on over to you.
Thanks, Ariana. We're going to have a couple polls and stuff throughout the presentation today, so bear with us if there's any tech stuff. But we'll kind of get through this and have some questions anytime. Raise your hand or jump in if you have any questions. So today we're going to cover Bacillus anthracis, or anthrax, and we're going to talk about a number of different topics here. So we'll go over sort of the bacteriology, epidemiology, clinical presentation, and then some of the things to think about with bioterrorism. This picture here in the bottom right is one of the letters that was sent after 9/11. This was the anthrax, biggest anthrax attack here in the United States. Killed 5 people and sickened an additional 17. And so this is at the lab where they're evaluating these letters. So that's one of the actual letters that was used. So this is Bacillus anthracis. It's an aerobic gram-positive encapsulated bacteria. It makes spores, which is part of the problem here. It's non-mobile and it's non-hemolytic. Spores are really the infectious form, and that's one of the biggest issues here, is because these spores can last for so long. Within this bacteria, there's 3 virulence factors that play a huge role into why this is such a concern from a bioterrorism consideration, and why it's really so infectious. So there's 3. The first one is an extracellular capsule. This basically prevents breakdown and allows this bacteria to kind of evade all of our body's natural immune response, so it can hide and last a lot longer in the body. There's also 2 exotoxins. One of them is called lethal toxin, obviously pretty clear on that term what that means, and then edema toxin. This is what's causing a lot of the swelling and immune response in the body. So both of these facilitate the immune system evasion, and they interfere with the native host's cell functions. Things like messing with the macrophages, neutrophils, and dendritic cell function. So basically, it has all these protective mechanisms to keep it alive in the body. It also inhibits the host's B and T cell immune functions. And then lethal toxin causes hemorrhage. So you see blistering and bruising, as well as apoptosis of endothelial cells in the vascular system, meaning that those cells start to become more leaky. You get hypotension, decreased central venous pressure, decreased systemic vascular resistance. So their blood pressure is going to drop. They get kind of warm, swollen, and it really causes severe systemic illness. So all of these together lead to a real proliferation of the bacteria. You can imagine that they're harder to catch because they have all these protective factors, and they're doing damage along the way. So this increases their morbidity, so how much they're affecting the outcomes of the patient, as well as their mortality. We'll do our first poll. So we know a little bit about the bacteria, but how many different routes of transmission are there?
And please keep in mind, to get to this poll, you'll have to click on the bottom right screen. There's 3 little boxes with a plus sign, so just click on that and then you can begin voting. Thanks.
We get a pretty good response there, Ariana.
Yep, looks like people are just about done, so I'm gonna go ahead and close
Great.
that. All right.
Okay. Are you able to share the poll results there? You got those loaded up there.
Let's see. All right, can everyone see this? Sorry for the WebEx technical difficulties here.
All right, so there are 4 routes of transmission. So we'll go over each of these and we'll talk about the clinical presentations a little bit later on how these show up. So there's cutaneous. So those are where the spores get through the skin. Typically, we think of these non-intact skin, cuts, abrasions, dry skin, things like that. But they can actually get through where the hair follicles are. So they can actually get through intact skin as well. Obviously, higher risk if you have an open sore, but the bacteria can get through the hair follicles. Ingestion is one of the other ways that this can happen, typically through infected meat in certain endemic areas. Injection, there were actually some cases years ago in Europe, in Northern Europe, where there was heroin that was contaminated with anthrax. And so they saw a number of cases with that. And then inhalational is one of the ones we are concerned about the most. This is through either bioterrorism, which we'll talk about, or through contaminated animal hides and wool is the other main reason, or main way, I should say, of how you can get inhalational anthrax. The person-to-person transmission is almost non-existent and very, very rare. You have to have extremely close contact, like breastfeeding, direct contact with the infected blood, not in the same way as many of our other infectious diseases. This is a map from Nature that shows kind of the global distribution of outbreaks in different areas. You can see, obviously, in Europe and Asia, the number of outbreaks is much more significant than here in the United States, but these still do occur kind of in the northern United States, Canada, around some of our farming land. So where does this happen? So Bacillus anthracis, anthrax, is really an endemic disease in a lot of places. It's what's considered a zoonotic disease in what are called ruminant herbivores. So antelope, cattle, deer, goats, sheep. These animals kind of pass this between themselves and humans, and that's why it's called zoonotic. So it goes between animals and humans, and it lives in some of those species in certain areas. And then the enzootic, those are primarily in the United States, Canada, and Western Europe, but not endemic, meaning it's not there, or native to that area or there all the time. And then in some places, it's enzootic and endemic, meaning that it's passed between animals and it's also in that area kind of at all times. So we see this primarily in sub-Saharan Africa, Central and Southern America, Central and Southwestern Asia, as well as Southern and Eastern Europe. So we still get outbreaks of this in livestock, in wild animals, and in livestock in the United States and Canada. A lot of this has been stopped through the vaccinations that have been done in those animals, but it does still occur here in the United States. Here's kind of the way this goes, right? So you have an infected animal, that animal dies from the anthrax, the bacteria gets into the soil, the spores particularly, they infest those agricultural fields. More animals come along, graze, ingest those spores, and the cycle continues. Those spores can live for months to years in that soil, depending on the climate. And so even if the animal died a long time ago, it could still potentially infect that herd if a new herd came through. So go to our next case here. What is the most common route of transmission? Cutaneous, ingestion, injection, or inhalational? Ariana, let me know when we're all set and I'll go to the next slide.
Sounds good. Give everyone maybe 10 more seconds. Put your answer in. All right. Should be good to go. See, are you able to see the poll results?
I can't see it from presenter mode, but can you guys see the results there?
Cool. Yeah, looks like we had about 33% of you got the right answer. So nice job, team.
That's good. That's pretty good. So why am I showing you pictures of drums here? So cutaneous route really is the most common way that anthrax is spread throughout the world. Obviously, it's not the one we're worried about the most from a bioterrorism concern, but it is the most common way. 95 to 99% of cases worldwide are cutaneous. There was actually a couple of cases in New Hampshire back in 2009, where they had imported drums that were made out of goat hide. And these drums caused a kind of a rash of cases of anthrax, no pun intended, of anthrax, some GI and some cutaneous in that area because they had a drum meeting, basically a drum circle, and a number of people got infected from that. So what about in the United States? So almost entirely this has been eliminated in livestock via vaccination, like we talked about. So since 2006 up until today, there's really only been about 9 cases, and that's confirmed and then probable. So 2 were inhalational, 1 was ingestion, 4 cutaneous, and then 2 they just couldn't know. The person tested positive, but it was impossible for them to decide or define where that infection came from. So very, very low case rate here in the United States. The reason we care is that even with modern advanced medical treatment, all the great cool things that we can do in critical care, mortality rates are still extremely high. Cutaneous, as you might imagine, has the highest survival, lowest mortality, but it's still around 2% or less. Inhalational is still, with treatment, with antibiotics, with aggressive critical care, is almost 50%. And then meningitis is a complication of any of the anthrax routes. It can happen with any of them. Obviously, the inhalational injection are much more common, but if you get meningitis with Bacillus anthracis, it's almost 100% fatal. How do these present? So we're going to walk through the different routes of presentation, and then we'll talk about some common features. So this is like out of a textbook, obviously, and it is the classic presentation of cutaneous anthrax with that black eschar there. You can see some edema and some swelling around that. And this is very classic for cutaneous anthrax. So the incubation period, so from time of exposure until you start showing symptoms, can be almost 20 days. Most people are going to present within 1 to 7 days. And it has a progressive presentation. So as you can imagine, most things aren't going to show up immediately as this is clearly anthrax. It's going to show up with kind of a painless papule. It's going to grow. It's going to turn into a vesicle. It then kind of ulcerates. It kind of looks like that volcano. And then it develops this black eschar over the top about a week to 10 days after that initial rash showed up. Once you see that black eschar, it's pathognomonic essentially for anthrax in this case. The edema that we saw, and you can see in that bottom right, is really key to this, is all that immune response and the swelling, as we learned about with those toxins. You can get some other vesicles, some redness or hyperemia, and lymphadenopathy, right, as the immune system's really trying to recruit all of its forces to fight this infection. And then you can have some systemic generalized symptoms, malaise, headache. Only about a third of patients have a fever. Classically, we're seeing this in the head, neck, forearms, and hands. You can imagine why, where you're going to be more likely to contact hides, dead animals, infected meat, things like that. Mortality, like we talked about, is still high. It's less than 2% with antibiotics, but a quarter of patients that don't get treated will die from this. So this is the most common route of presentation, and it's still something that is very important to treat. It still, even though it's just cutaneous, can lead to the meningitis, which is obviously the most severe complication. Okay, what about ingested anthrax? And so this a lot of times comes from those endemic and zootic areas where the meat, and especially goat meat, is contaminated. And so similar incubation period, about 16 days, same thing, about 1 to 7 days after eating the contaminated meat. they will start to show symptoms. And you're going to have a little more systemic illness with this, as you can imagine. You're having a lot more of immune response, fever, chills, and there's two primary ways that this presents. So you can have oropharyngeal, so mouth, back of the throat symptoms. So sore throat, which is obviously going to be pretty severe, trouble swallowing, neck swelling, lymphadenopathy, and it can lead to airway compromise and death. Obviously, this fits with 900 other causes of a sore throat, right? So strep and viral symptoms, all of these are a lot of symptom overlap. And so it could be pretty challenging to identify that particular symptom set as anthrax. Intestinal, same kind of problems, right? Nausea, vomiting, diarrhea. It can be bloody either side. And they can develop ascites and coagulopathy. So their clotting ability is messed up. They can't stop bleeding. They might clot more. And then they can develop more systemic severe symptoms like shortness of breath, altered mental status. And then with those toxins, right, we talked about they're decreasing their systemic vascular resistance and their blood pressure drops. They suffer shock and they will die. Usually it's pretty quickly, 2 to 5 days after the onset of the symptoms. So without antibiotics, more than 50% of these people will die from this. And even with antibiotics, it's a pretty significant disease. Still, almost 40% of people are going to die from an ingested anthrax. So big deal if it does happen. Let's talk a little bit about the injected anthrax that was contaminating the heroin in northwestern Europe. So pretty rare now, less contaminants there, and obviously a lot more of our drug supply is in the fentanyl form, but there's a lot of contaminants in those, as we know. So typically much quicker onset, 1 to 4 days after exposure. Those symptoms are pretty severe soft tissue infection around the site of injection. So similar to the cutaneous, you're going to have swelling, erythema, and more bruising at that injection site. Most of these become septic, because you can imagine you're putting that bacteria directly into the bloodstream. And then the pain might be less than anticipated for how it looks, meaning that the wound itself might look really gnarly and pretty painful, but maybe less painful for the patient than it should in the way it looks. And then even with treatment, almost 30% of these patients will die. We covered cutaneous, we covered injected. So now we're going to talk about the inhalational anthrax. And we'll talk about this chest x-ray in a little bit. But you can see some of the abnormalities if you ever look at chest x-rays. There's some swelling and some edema along the mediastinum on both sides, as well as a pleural effusion down here on the right. And we'll talk about that here in a minute. But the inhalational form is the one we think about and worry about the most from a bioterrorism perspective. So what's interesting with inhalational is that these spores can live for a very, very long time in the body. And so the incubation period for an inhalational exposure can be up to 2 months later. So you could have your index exposure, excuse me, and then 2 months later start developing symptoms. Most people or typically are going to show up within about a week. And so a lot of this overlaps with other viral bacterial infections, right? You're going to have fever, chills, malaise, cough, shortness of breath. You have some chest pain, nausea, vomiting. Really, that's the flu season for a lot of people, right? And that makes it pretty complicated to identify. So symptom progression over days. They'll initially have those kind of vague symptoms and it'll progress. Shortness of breath, cough, chest pain becomes much more common. And then they can develop altered mental status, sweating, and severe headaches in up to a third of patients. And then what we consider fulminant is where they have altered mental status, shortness of breath, and are kind of systemically severely ill. Mortality rate prior to 2001 with treatment was 90%. That was with treatment. And now, even with aggressive care, like we talked about, it's still almost 50%. And a reminder that the likelihood of person-to-person anthrax infection or transmission is very, very, very low and very rare. There's unlike many of our other infectious diseases. And then anthrax meningitis, a complication of any of those 4 presentation types. Sometimes that might be their only presenting symptom is severe meningitis. And so we call that primary anthrax meningitis, where they may not actually be able to identify where the infection came from, just the severe complication from it. 50% of those come from a cutaneous source. Part of that is also because that's the primary route where most people are getting their anthrax, as we talked about earlier. So hematogenous spread, right? It gets into your bloodstream from somewhere and seeds the brain, and you develop meningitis. Severe headache, altered mental status, and confusion, kind of your classic meningitis symptoms. So they're having stiff neck, headache, photophobia, phonophobia, confusion, and then they may have acute neurologic deficits, cranial nerve deficits, strength and sensory deficits as well. And up to 2/3 of them actually will have a hemorrhage as well. Mortality is almost 100%. It's so significantly fatal despite maximal treatment. Knowing that, what do we consider probably the most important part, or what's the most important factor in diagnosing an infection with anthrax? So we're going to get into some of the diagnostics here.
All right, give you about 10 more seconds to put your answer in.
Great.
All right, we got a pretty smart group here. Got 60% got the right answer.
Perfect. Perfect. Which is history, right? So as I alluded to, there's so much overlap. And obviously this is the case with a lot of our emerging diseases and infectious diseases, is that the history is really the key here, right? Did they have travel or a specific exposure? And like we talked about in medicine in general, the answer is always at the bedside, right? There's a lot of expensive tests and things we can do, and I'll show you kind of the stepwise approach that you can do, and we probably will do in that circumstance of what kind of testing can be helpful in making the diagnosis. But at the end of the day, the answer is at the bedside with the patient. It's asking them questions, getting that travel history, kind of pushing them to help you make the diagnosis. So what do we care about? Travel, any kind of new rash, have they traveled to an endemic area, any specific animal contact, especially in some of the travel to Africa. Were they on a farm? Were they eating new meats? Were they at a drumming event? Those types of questions obviously are very specific to anthrax. But as part of your general travel history, asking about animal contact, where they were, how long ago too, that incubation period is very important. So gathering a good history is going to be really key to making this diagnosis. And then the next few slides, we'll talk a little bit about some of the lab tests that are available. As you can imagine, this is considered a nationally notifiable disease. There's a number of those out there. Obviously, this is important for tracking at a national level. Reference labs around the country can do confirmation testing, and then CDC can do very detailed like tracing, essentially, of where these strains of anthrax came from. So they can do much more detailed testing. So let's talk about some of the tests that actually exist, right? So a CBC, as you can see on the top, the initial presentation versus the serial monitoring kind of shows what you might expect to see. So hemoconcentration, low platelets may not be present initially, and then leukocyte counts frequently are normal or at the reference level on that initial presentation. They can develop anemia, thrombocytopenia, so low platelets, and they can also develop hemolytic anemia as a result of the anthrax. And then leukocytosis, or an elevated white blood cell count, usually is not seen until a lot later in the disease. So as you can imagine, especially with my purview in the emergency department, it's not going to be that helpful. It'll be very nonspecific and probably not clue us in too much to the diagnosis. What about a few other labs? Electrolytes, renal panel, lactate, kind of vague, right? You might have low sodium, bicarb levels may be normal, even with sepsis. They may have an elevated BUN. Again, a lot of this is very nonspecific, and in retrospect may help kind of be shown at the end, right? Like, oh, look, it was low on initial presentation, but you're not going to look at this and say this is clearly anthrax. Liver enzymes might be mildly elevated, might have a low albumin. Albumin is kind of an acute phase reaction, so sometimes it's elevated, sometimes it's low. Not helpful. What about some of the coagulation labs? PT, PTT, D-dimer, fibrinogen, probably going to be normal at presentation. But that does not exclude the fact that this can develop further on in their course, and most of the time will. So they'll develop a coagulopathy or even DIC, where they're clotting and bleeding, and it's kind of the last stage before the fatal illness, essentially. So having a low threshold and getting a baseline for those labs can be helpful, especially early on in the disease, just to be able to detect that progression. And then what about inflammatory markers like the ESR, CRP? Again, it's kind of for trending, but really doesn't diagnose or rule out anthrax. Cultures obviously are going to help us truly identify this and sending this off to reference lab testing. So the initial testing on any accessible fluid, blood, serum, CSF. If you do a tap and they have a pleural fluid drain that you can send, ascites from the wound itself. If you do a bronch and you aspirate, any of those can be sent for culture. They are usually going to be negative if they've had antibiotics, but the toxin may still be detectable. So if you're concerned about it, sending culture is obviously going to be the primary way we diagnose this. What about cardiac enzymes? Beta natriuretic peptide. Again, fairly non-specific. You can see cardiac demand from the acute infection and have some troponin leak or AFib and troponin leak from that. But again, it's not going to be diagnostic. What about EKG? AFib and RVR, so fast AFib rate, is common in anthrax infected patients. And then what about the chest X-ray? I'll show you a picture of that on the next slide. This does have a fairly characteristic appearance with widened mediastinum as well as pleural effusions. They may not be as obvious as this symptom here, where you can see definitely on the patient's right here, this is much more swollen. And there's blunting of the costophrenic angle here, meaning if you look at the other side, you can see the air all the way down into the sulcus here. Here it's pretty white and blunted. So there's fluid in here. Obviously, if you don't have a good history, you're going to see this and think, maybe they have heart failure, maybe they have some pulmonary hypertension. But with the right history, you would see this and be more concerned about anthrax. So you have a high clinical suspicion, you've done a great history, you've identified they had a recent exposure or travel. You have a couple of the labs and chest x-rays kind of cued you in, and now you're going to treat them for anthrax while you await confirmation testing. Because you're not going to wait for testing, we're going to treat empirically right away. So what about cutaneous treatment? This is the simplest. Localized, uncomplicated cutaneous anthrax is treated typically with 1 week to 10 days of an oral antibiotic. There are a lot of apps out there that will give you the most up-to-date recommendations, but typically we're thinking ciprofloxacin or doxycycline. Doxy works for almost everything, it seems like, and is a great first choice. What about with systemic symptoms? Tachycardia, tachypnea, hypotension, fever, hypothermia, leukocytosis, or large, big, multiple lesions? We're going to treat as a systemic infection. So we'll talk about that in the next slides here. So if they have a simple wound, isolated, no other systemic stuff, about a week to 10 days of antibiotics. If they have anything else going on, they're going to get treated as systemic. So how long do patients stay on antibiotics if they're treated for inhalational or systemic anthrax?
All right, about 10 more seconds. All right. Looks like 1/3 of you got the right answer again.
We kind of alluded to this earlier, but yeah, 60 days. This is one of those, you're on antibiotics for a very, very long time. And it's related to those spores that live in the lungs, especially with the inhalational anthrax. So systemic treatment, obviously, like with anything bad in medicine, we're going to always say aggressive supportive critical care, right? So fluids, close critical care monitoring, central lines, dialysis if needed, all the typical supportive care measures. But specific to anthrax, typically we're going to treat with 3 or more antibiotics at the same time. Most of these, at least 2 of these, should have bactericidal activity, meaning that those antibiotics are actually killing the bacteria. And then one of these is actually going to have protein synthesis and inhibition, a mechanism of action. So the main reason we do that is an exotoxin target, essentially. So we're trying to prevent the toxin from being built. And so one of those antibiotics, at least, if not more than one of them, should inhibit protein synthesis. And that's going to help prevent the exotoxin, which is going to hopefully help reduce some of the morbidity and mortality. So 3 or more antibiotics, at least one with protein synthesis inhibition. They're going to get treated for at least 2 weeks until they start improving or stabilizing, at least 3 weeks if meningitis hasn't been ruled out. So if you can't get an LP for whatever reason, they're going to get covered for even longer. What's interesting is, we talk about 60 days. There's been studies that some of these spores have been seen and found in the lungs of primates, non-human primates, for up to 100 days. So they had their index exposure, and then 100 days later, you can imagine that the risk here is that if you get treated for inhalational anthrax, you're better. It's been 3 weeks. Your meningitis is better. You're the one of the 6% that survived. You could still reinfect yourself with the spores that live in your lungs. And so these patients are going to go on a 60-day or more regimen of oral antibiotics, even after they're completely back to normal. So they're on a very, very long course of antibiotics. So again, there are a lot of reference articles out there. The CDC has done a number of updates over the years that talk about different antibiotic regimens. So, but as you can see, even on here, the bactericidal agents, so we're picking at least 2 of these, meropenem, Cipro, Levaquin, and then a couple of the other ones are less first line and more for if you have allergies or prior side effects of some of the other medications. And then protein synthesis inhibitors, these are ones that we're talking about. Again, doxycycline, great for most things, are going to help reduce that toxin effect. Don't memorize these. They're there to look up, but recognize that this is more complicated than our simple, you have pneumonia, you're going to get a dose of ceftriaxone and maybe 5 days of azithromycin. They need a very, very prolonged and aggressive course of antibiotics. What about post-exposure prophylaxis? So what does this mean? So asymptomatic exposure to aerosolized anthrax, that's primarily what we're talking about here. This is somebody that, was in the room when a letter got opened with anthrax in it. What are we doing for these people? So immediately they're going to get started on a 60-day regimen. So 2 full months of treatment. Again, it's that spore issue for prophylaxis. Ciprofloxacin, doxycycline, Levaquin. These are going to be the principal antibiotics that are used. There's also now a 3-dose series of an anthrax vaccine called the AVA or Biothrax anthrax vaccine. And so this is recommended to be given at day 0, essentially. So right when exposed, and then again at 2 weeks and at 4 weeks to help prevent, kind of the conversion of that into an active anthrax infection. Quarantine is not necessary. This is something that you're exposed to, and there you are, you have it, and there's not a lot that you're going to risk other people by being around them. So quarantine is really not necessary, not contagious. If you're around the source of the inhalational anthrax, we're talking about hazmat teams, full breathing, self-contained breathing apparatus, HEPA filters, splash protection, basically trying to keeping it out of your nose, mouth, eyes, any kind of open area. As we talked about before, the cutaneous version can still get through the hair follicles. So making sure you're protected if you're going to be in that environment. So we've alluded a lot about some of these considerations, but what does this mean from a bioterrorism consideration, right? We could talk about infecting the meat. We could talk about, infecting the agricultural land. But the biggest concern here, honestly, is the inhalational, right? And so in a bioterrorism situation, we're talking about the intentional release of a virus, bacteria, or toxin with the sole intent, truly, of harm and disruption. So harming people, livestock, crops. Bacillus anthracis is part of the Federal Select Agent Program, which is jointly managed by the CDC and the USDA. And so this was created back in 2002. You can imagine after that anthrax event in 2001, this was obviously a big instigating factor for this. Part of the Public Health Security of Bioterrorism Preparedness and Response Act, so sometimes just called the Bioterrorism Act. So it increases security and oversight of specific agents and toxins and regulates who's allowed to have them, use them, possess them, transfer them, and work with them. And so here's a list of the HHS select agents and toxins. Number 2 being anthrax. If you scroll through some of these, we talk about botulism, other things that you can think about that are going to be really disruptive and fatal or universally morbid or high mortality rate for humans, right? So tularemia, Marburg virus, which is obviously pertinent to what's going on, monkeypox. All of these are very concerning. Obviously, COVID's on there too. because of how infectious they are and what they're capable of. So anthrax is considered a tier 1 select agent, meaning the most concerning. And it's one of the most likely bioterrorism agents. You can probably guess why, but very easy to acquire from the environment, right? It exists naturally. It's something that's not too hard to mass produce. And because of the spores, it's easily aerosolized and can decimate an entire group of people very quickly. So in 1975, there was the Biological Weapons Convention, and 180 of those countries signed basically an agreement that prohibited the development, production, acquisition, transfer, stockpiling, and use of bioweapons, including anthrax. But obviously, that doesn't prevent those types of things from occurring. But there's definitely attention to this at the local, national, international scene. Going back to that case we talked about kind of at the beginning. So in 2001, in the setting, around the 9/11 attacks time, spores were sent in letters throughout the U.S. Postal Service. So 11 of those cases were inhalational, 5 of which were fatal. That's about what we were talking about, right? 50% fatal, despite aggressive treatment. Back in 2001, treatments weren't nearly as good as they are now, but still, despite their best efforts, then those people died. There were also 11 cutaneous cases. 10,000 people were considered at risk of exposure. You can imagine if you do the contact tracing for, the letter that made its way through the Postal Service, through the different people that handled it until it got to the person that it was intended for, thousands and thousands of people were considered at risk. And it's still considered the worst biological attack in US history. So the other concerns with this is that genetically engineered Bacillus anthracis could potentially be more resistant to our first-line antibiotics, right? They can make stronger toxins, stronger spores, essentially, that are going to be able to evade our hosts. So that's the biggest concern. And then large attacks, if we had a very large population affected, those initial doses of 3 weeks of IV antibiotics and 60 days of oral antibiotics would probably have to be adjusted, kind of like we saw during COVID times, where we're starting to have to ration some of our antibiotics. And there are different dosing regimens that exist in, kind of in the pre-planned stage if that was to happen. You can imagine that we would very quickly run out of our antibiotics, even with our strategic national stockpiles. There's just not enough if we had to, treat 1 million people. So things to think about. And then this is an interesting book that was published called Pre-Positioning Antibiotics for Anthrax. And so it talks about this kind of in a conceptual way of how would we actually, antibiotics people that were exposed, right? So if you haven't already, it's easy to look up. Obviously, they don't tell you where they are exactly, but the Strategic National Stockpile, these are basically packages of medications and strategic things that are determined to be what we want to be able to have in an emergency, neurotoxin antidotes, things like that. They're strategically staged around the country. And then with that, there are also state stockpiles. And then there's other strategic national stockpiles through vendors that are also kind of pre-planned. So if those get activated, those would go basically to a distribution center where they're going to be kind of sorted and decided where they're going to go. And then they're going to go to a place that either people are going to push them out, like through the U.S. Postal Service, right? Like during COVID, we were mailing out COVID tests to people. So the post office is great for being able to push things to people in a pretty organized way. Or you're going to have people coming to a pod or like a point of dispensing is what it's called, where you would come to a rec center or a school and get your dose of antibiotics and your vaccine. And so there's kind of two approaches to that. There's whole courses and lectures that you can take on how to actually prepare for something like this. But the Strategic National Stockpile is probably not going to be enough to really counteract a big terrorist attack without a lot of other local resources. The SNS is part of ASPR, the Administration for Strategic Preparedness and Response. So there's a lot of alphabet soup and acronyms out there with a lot of overlapping agenda and goals, but the point being that there's some preparation going on. The biggest thing is trying to prevent something like this from occurring. We've seen what happened in 2002 or 2001, excuse me, and that was overall a pretty small event, 10,000 people at risk and, number of fatalities, but you can imagine how much higher risk there is if there was a genetically engineered Bacillus anthracis that got released. So things to keep you up at night. But we've talked about the antibiotics, we've talked about what to look for, and the biggest thing here is to have that high clinical suspicion. If you see a case of anthrax, most likely it's going to be from a traveler that was around endemic animals that had an exposure. But these are the things to think about as we look towards a bioterrorism concern. That's really all I have for anthrax, but we do have some time here. If there's questions or other things that we didn't talk about, or you want me to go over with a little more detail, happy to take any questions. Otherwise, we'll get you out a little early. I think Dr. Richards, you had a question?
Hey Shay, thanks. Great talk. I was wondering if you could talk a little bit or know much about the immunizations and what populations are currently getting immunizations, and if that's part of a strategy for response at all.
Yeah, it's a great question. There's one primary immunization, the AUA, that I was talking about. Primarily in the military and high-risk people, they're vaccinating prophylactically. Some travelers, I think, depending on where they're going, if they're going to be like working in an anthrax embedded, zoonotic area, they'll get prophylaxis. But generally, there's no broad prophylaxis going on. If there was a major exposure or bioterrorism, there are different strategies of doing either a 2-dose series or a 3-dose series to help reduce the risk of people contracting anthrax. But it's usually paired with the antibiotics. And so you can imagine if we got into a really hairy situation where there's not enough to go around, that some of those dosing adjustments are going to have to be made kind of quickly, whether you go from 3 to 2. What I was reading, there was never really a dose adjustment down to 1 dose. It seemed like you could go from 3 to 2 and still have pretty good prevention of infection, kind of a post-exposure prophylaxis, kind of like we do for rabies, is what I was kind of the way I would kind of think about it. But yeah, there's not a lot of broad preventative for people except the high-risk military.
Cool, thanks.
Except Richards.
Looks like we have a question in the chat. I was under the impression that some people will be able to get PrEP like some farmers. Is this true?
I'm sorry, I didn't understand. To get pre-exposure prophylaxis?
Yeah.
Yeah, I think through their health department, they can if there's like a demonstrated need. If somebody is like truly working, like they have a known outbreak and they're going to be working with those animals, yeah, I think you would go through your local public health and potentially even the state health department to be able to get access to it. It's not something that the general primary care doctor is going to have access to. So going through the health department's your best bet.
Great. And thanks, Adam Sorensen, for the DoD vaccinates prior to deployment call out. All right. Any other questions from the group?
Yeah, hi, this is Claudia Conrad from PEDS and PQ. Thank you for the great presentation. Very interesting. Hopefully I won't have to treat anybody with anthrax, but I have a question. So, and I was a little late, apologize. So if the patient, the patient has been exposed, the best is the vaccine. Would antibiotic treat the patients as well? And do we need to do 3 of them?
Yeah, generally from what I was reading, if you had an inhalational exposure, they're going to get prophylactic vaccine at the 0, 2, and 4 weeks. And then they're also going to get treated with post-exposure prophylaxis antibiotics because those spores can live for 2 months in the lungs or more.
All right. But there's probably not really data, right, in how efficient that is, or there is?
Probably not. I didn't see any randomized trials, head-to-head trials for one versus the other. I think a lot of this is kind of anecdote. There's a second vaccine that got released, but it doesn't look like it's fully FDA approved from what I was reading for prime time for this. But there was a second vaccine that was pretty recently developed that had a different series. But the AUA one was still kind of the primary vaccine for anthrax.
All right. Thank you very much.
Thanks, Dr. Conrad.
I actually have a question, if that's all right. What additional considerations would you need to think about with any pregnant people considering, antibiotics like Doxy are not recommended? Are there other methods or things to think through?
Yeah, certainly. And as with most studies, there's not a lot of good data on pregnant patients, especially in such a low frequency event. So really what you're going to be left with is tailoring antibiotics to that patient status, right? So finding antibiotics of that long list that exists that are pregnancy. Nothing's really ever pregnancy approved, but at least has lower risk for pregnancy. But yeah, and a lot of it's going to depend on how far along they are too. If they're at a post-viable stage, right? If they're over 20 to 24 weeks, depending on where you work, you're going to really want to coordinate with your OBGYN colleagues to think about whether you deliver early or do we try to, treat aggressively and stabilize depending on how sick the mom is. And obviously placental, the anthrax could clearly could cross over into the placenta. And even if it didn't get to the fetus, the complications from the anthrax is obviously going to have pretty significant effects on that pregnancy. So aggressive supportive care, antibiotics that are going to be safe enough in pregnancy. And I say safe enough because nothing's perfect in pregnancy. And then coordinating with our OBGYN colleagues about a delivery window if we're within that viable stage.
It's interesting. Thank you.
Yeah, it'd be complicated for sure.
Yeah.
Great questions. Anything else from anybody?
Any questions that come up, feel free to reach out to the HIT team, or we'll make sure that we get those questions over to Dr. Gillum. I want to just say a huge thank you for presenting today. I know I learned a lot, and I'm sure it was very, very helpful for everybody to be listening in. So huge thank you for doing this for us, and for everyone on the call. Thank you for attending, taking up a little bit of your Friday. With that, we'll go ahead and wrap it up. Dr. Gillum, anything to add?
No, just say thanks for having me. I really enjoyed being here. And if you have questions, please send them along. Have a great afternoon.
Have a great Friday, everyone. Thank you.